much for coming out. I think you brought the sunshine with you. That's unusual for our forums. For those of you who come all the time, you know that it's usually raining or snowing or winds blowing, but now it's perfect out. So thank you so much for coming. And for those of you who couldn't make it and are watching us on Facebook Live, thank you for coming as well. I see a lot of new faces tonight, so I just want to tell you quickly about our program for those of you that don't know. We have been on the Adelphi campus for almost 40 years. We provide various different supports to women and men who are diagnosed with breast cancer. We offer individual counseling, support groups, these educational events, and then we have a community outreach program that goes out into the underserved communities. We provide bilingual social work services, excuse me, as well as our wonderful hotline, which is answered 365 days a year by survivors who are all volunteers and volunteer their time to talk to women who've been diagnosed with breast cancer. So as you know, we are here tonight to talk about an interesting topic that we've never talked about before, and we're really looking forward to learning more about that. Dr. Martins-Welch is a board-certified palliative medicine physician and medical cannabis clinician who works at the Northwell Health System. She has a particular interest in studying the effects of early palliative care for cancer patients and medical cannabis for management of symptoms. Tonight she will be discussing the potential medical benefits of cannabis and the basis for how cannabis works in the human body via endocannabinoid system. Yes, got it. So please give her a warm welcome.
Hi, I'm excited to be here and happy I was asked to come speak about this topic that I love to speak about and educate the public about. I'm a little short, sorry. All right. So I was asked to speak about the benefits of medical cannabis in cancer patients, and this is a topic that I know a lot about. I work at Northwell's Cancer Center. I'm a palliative medicine physician, board certified in palliative medicine and internal medicine, and got involved with the medical cannabis program in New York State upon its inception 3.5 years ago. So I'd like to say I'm well versed in medical cannabis as well as New York State's program, which is always changing and evolving. No disclosures. So my objective is, my objectives for today are to relay the history of medical cannabis, so I'll briefly touch on that, cover the basics of the human endocannabinoid system, review the major phytocannabinoids and their medicinal properties. This is THC, CBD, I'm sure you've heard these acronyms, and then review some of the evidence or lack thereof for cannabis's therapeutic effects, and cover the New York State Medical Marijuana Program. I'm sure there's lots of questions, so I do want to leave ample time for that. So this is a map from, I think it was most recently updated in January of this year, the states that have legalized both medical marijuana as well as recreational marijuana. I think the latest count is 34 states and DC, so more than half the country at this point has legalized at least medical cannabis in some form. The tide is turning, and we need to get with the program, at least those of us in healthcare, because we're getting these questions on a regular basis. So what is cannabis? It's a genus of flowering plant that's native to Asia. It has 3 subspecies, sativa, indica, and ruderalis. There's over 400 chemical compounds that are produced by the cannabis plant, 60 of which are unique to it. And these are known as the phytocannabinoids. So these are what I refer to as THC and CBD. These are phytocannabinoids. If you remember back to high school science, phyto means plant. So the biological components of cannabis are many. So up at the top, you see the THC and the CBD. These are known as the major phytocannabinoids. There are also minor phytocannabinoids. Some of them are the CBG, CBN, and many others. The terpenes are these aromatic compounds that give the aroma to cannabis and also provide some benefit when they're taken medicinally. It's sort of this compounded effect with the other components. Carotenoids, fatty acids, sterols, vitamin E. So it's not just about the THC and the CBD. There's many other compounds that you can find in the plant itself. So what people didn't understand for many, many, many years was why cannabis had any effect on the body the way it does, therapeutically. And it wasn't until the 90s that the endocannabinoid system was founded in Israel by Dr. Raphael Michel. And it was only then that they realized that there was this innate system that's in our bodies, and that has receptors, and there are both receptor and non-receptor mediated effects that THC and CBD and the other cannabinoids take advantage of. And so we are sort of primed for cannabis, so to speak. I include this slide because I hear, as a cannabis clinician, I hear there's a lot of naysayers, there's a lot of people out there who have a lot of negative things to say about it. And I grew up in that era where it was just say no. And so up until educating myself on the topic, I also fell into the realm of, marijuana's bad, and there's something I wouldn't do. It's, those are people who are sort of at the outskirts of society. I was sort of a prude, and so I hear a lot about, it's dangerous for you. You can't take it and drive, and there's accidents, and I understand all of that stuff. But when we talk about what's legal and what's probably more harmful, and you look at the toxicity of things like opioids and alcohol, cigarettes, all these other things that are legal and addictive. And the toxicity profile is really, there's no comparison. You need to take an insane amount of cannabis in order to lethally overdose. And in fact, there's been no documented lethal overdose from cannabis to date. People may do stupid things while they're high and die as a result, but nothing as far as an overdose. And that's because cannabis doesn't bind receptors in the medulla oblongata in the brain where our respiratory centers are. So some of the history, this is not a new drug. People think that this is like new and hot. This goes back many, many, many years, back to ancient China, and then it's traveled to ancient Egypt and India and Greece, and it made its way around medicinally for many years BC. And in the 1500s, it was brought over to the Americas by the Spanish. It wasn't until in the 1850s it was in the pharmacopoeia, the U.S. pharmacopoeia as a drug. This was included in a plethora of different medications. Cannabis was in there, and it wasn't until the 1930s when Harry Anslinger sort of had a vendetta. He was sort of like the drug enforcement agency of then, and he made it a big propaganda scheme, and then it got taken out of the pharmacopoeia, and in 1937 there was a Marijuana Tax Act that banned cannabis use and sales, and later it became a Schedule I substance by the Controlled Substance Act in 1970. Yes, he was the first director of the Federal Bureau of Narcotics. So it all sort of goes back to him. People demonize him now because he really had a vendetta against cannabis. In fact, that's why I call it cannabis, because marijuana has a tie to, they use marijuana, which is the Spanish word for cannabis, to sort of, make it more of a racist tie. Like, well, that's what the Mexicans do, and we don't want to mess with that. That's what the black people in the jazz era do. And so it was a very racist root, and I'm not sure everybody understands that when we talk about the history of marijuana. So back to the science. So what is the endocannabinoid system? So this is a network in the nervous system. It regulates synaptic neurotransmission, and both excitatory and inhibitory. So basically it can upregulate, it can downregulate things, And we naturally produce our own cannabinoids, hence why we call it the endocannabinoid system. What we produce is the endocannabinoids. What the marijuana plant produces are the phytocannabinoids. So our endocannabinoids interact with specific receptors found on neurons and immune cells. They act to reduce excess nerve activity and suppress inflammation. This is why we know that CBD works for patients with seizures by suppressing that nervous system activity that's in overdrive. There's three main components to the endocannabinoid system. These are our endogenous cannabinoids. They're coined anandamide and 2-AG. I'm not sure why they didn't come up with a better name than 2-AG. Anandamide comes from the root of Sanskrit for bliss. So, and they sort of said, well, this is sort of what makes you feel blissful when it's bound, when it binds to your receptors. There's the receptors, the CB1 and the CB2. And then we have enzymes that break down the endocannabinoids after they're made. They're really made on demand. The endocannabinoids in anandamide and 2-AG are produced, and then they're broken down after they're used. This is just what they look like. So the CB1 receptor is mainly found in the central nervous system. So the brain, the spinal cord, that's where you'll find the CB1 receptors. I don't want to get too much into the nitty-gritty, so I'm going to get past this. And just I'll point this out, that this is where the CB1 receptors are found and why there's so much activity in the brain when cannabis is taken in, whether it be in the nervous system, pain receptors, and nausea receptors, and whatnot. There's also CB2 receptors. These are not so much in the central nervous system, they're more in the peripheral. So you see them mainly in the immune cells. And I'll just leave it at that. And I like this schematic just because it shows you where the CB1 receptors are and where the CB2 receptors are. So if you notice, the light blue is mainly in the brain and the spinal cord, and the CB2, as I said, is more in the periphery of the body. And you have the receptors there, CB1 and CB2, with those phytocannabinoids represented as keys, that they fit like a lock and key into our innate system. So I actually had the opportunity to see Dr. Raphael Michel, the founder of THC, endocannabinoid system, CBD, the father of medical cannabis, speak, and I took this from his slide. Actually, he put this on there. And it just goes to say that there's so much potential for medical cannabis. I think we're just scratching the surface, actually. So some of the reasons that people use medical cannabis, the vast majority use it for pain relief. Many people use it for sleep. Interestingly, it's not one of the qualifying indications in New York State. Relaxation, spasms, anxiety, appetite stimulation. Now, in working in a cancer center as a palliative care physician, that's probably the number one reason I certify patients is for appetite. So these are some of the potential therapeutic benefits of cannabis. So it covers a full spectrum of different issues that much of the population does suffer from. So THC. I just wanted to include some of the main things that THC is responsible for. Yes, it is the psychoactive component of cannabis, and every time I do a certification, I educate patients on, how much THC we should be starting off at. If they're THC naive, as I call it, if they come in and they're smoking every day, and that's a whole different story. But most of my patients aren't, and we have to start really low and go up slowly. And so it can definitely cause you to become high if you take too much. Doesn't matter if you're not smoking it, if you're taking it in oil, if you're taking it in a capsule, it's THC. It binds those receptors, and if you take too much, it will make you high. So you have to be, cautious when taking it. And what does that feel like? It's usually an initial euphoria, relaxation. It can affect the memory and cognitive perceptual abilities. However, I always ask people when I'm certifying them, have you ever used it? Most of my patients tend to be in their 50s, 60s, 70s, and many of them will, talk about their teenager, 20s, and when they took it in college and what happened. And I'm always interested to find out because it might give me a glimpse as to how they'll respond to THC. There's generally two camps of people: those who just become relaxed, sort of pensive, everything's sort of just floating, and then there's those who are sitting in a corner, anxious, paranoid, and hearing voices. So when I hear about the paranoid type, I'm extra cautious with how they dose it. It's been said that there's some immunosuppressive and immunomodulatory properties of THC. This is not a well-studied area. It can affect the cardiovascular system. It can cause fast heart rate. It can cause drop in blood pressure. So these are patients that you want to be cautious with. If I have a patient with heart failure, for example, I want to be extra cautious with dosing THC. But it works like an analgesic. It works as an antiemetic. It works as an anti-nausea medication, and appetite stimulants. It helps with sleep. So those are the big ones. And CBD is very different than THC in many respects. It doesn't have, now I don't go as far as to say that it's not psychoactive, because it's an anti-anxiety, so it sort of is a relaxant. So in that sense, we can say it's psychoactive, but I say it's not intoxicating. So it's not intoxicating. It doesn't give you that high or that cognitive disturbance like THC might. What it's known for is working as an anticonvulsive. It can have its own analgesic properties. Not so much the same mechanism of action as THC, although this is not very well understood. But it's an anti-inflammatory, so I think by way of being an anti-inflammatory agent, it's exerting its anti-pain properties. Certainly it works as an anti-anxiety. People say it works as an antidepressant. There really aren't any good studies to say it, but I have plenty of patients who use it for that reason. And so anecdotally, it does help. That's all I'll say about CBD. So just to note that there are medicines that are FDA approved out there for that are cannabinoid-like medicines. Dronabinol. This is a Schedule III medication. It is synthetic THC, so meaning that it's not from the plant. It's made in a laboratory to look just like THC, and it works the same way. It's approved for two indications: chemo-induced nausea and vomiting, and loss of appetite and wasting associated with AIDS. So I use it a lot in patients who either can't afford the medical marijuana program or what have you. Or some of my patients, aren't legal residents of New York State and they can't get onto the program. So dronabinol is an alternative, although it's not great. And the same thing goes with nabilone, although that's not really used as much in the chemo-induced nausea vomiting world. But I find it to be a very poor substitute for the real thing, because you're not getting all the other goodness that comes from the plant that makes it work so well. And so what I find is a lot of patients do end up getting really sleepy, drowsy with it. Some of them are getting high off of it because it's just not, it doesn't have the other elements that balance out THC's effect normally. The Biximols are not FDA approved in the United States. They are used in other countries, mainly for MS symptoms, spasticity. So this is a well-known effect of CBD and THC. It's like an anti-spasm medication. And then there's been good literature put out on that indication. So for whatever reason, it's not approved in the US. I include rimonabant because, in essence, you think about, if binding the CB1 receptor increases my appetite, well then the pharmaceutical companies got interested in, well, if we can antagonize the receptor, will we actually help people lose weight? It doesn't work that simply though, because what happened was they tried it out. They did some clinical trials, and people were committing suicide because they were becoming just completely psychotic. You don't want to mess with, what we have going on already. So they realized we can't antagonize the CB1 receptor and just expect it to be a nice clean cut effect. I'll skip over these. Now, a lot of people ask me, well, once I start cannabis, I'm going to stop the oxycodone, right? And I'm going to stop my morphine. And I say it's not that simple, It depends on what the indication is, that they're taking the medication for, and many of my patients have cancer pain, and that's not something I necessarily want to mess around with and expect that cannabis is going to come into the picture and solve all their problems, especially if they're on high doses of opioids. But what's been found is there was a small trial back in 2011 that was done, a controlled study on patients who were on long-acting opioids like OxyContin and short-acting opioids, and they found that the patients were having increased levels of opioids in their system once they inhaled cannabis. What they were having was better pain relief. There's some sort of synergy that happens when patients are taking opioids along with cannabis, and it's not necessarily something that's toxic. Now, of course, this was a controlled environment, but I think that it's something to be said for patients with pain. Now, what we hope to do is once we start them on medical cannabis, that we're able to taper down opioids. And I do see plenty of patients who are able to come off of opioids with the help of medical cannabis. And I can get more into that later as to how that's sustained. Some of these patients can't afford to keep up with the cost of medical cannabis. $300-400 a month sometimes they're paying, and that becomes a real burden to them. And it's easier just to have your health insurance cover your opioid. So that's a whole different story. Neuropathic pain is an indication that THC and CBD have been helpful for, and there's been good studies out there for it. So I just include these. This is something I include for people who more when I give my healthcare professionals this talk, because there's not a lot of studies out there that are robust on cannabis, but there are some, and neuropathic pain has been well established. For nausea and vomiting, we have those medications, the dronabinol, the nabilone. So there's definitely something about THC that helps with nausea and vomiting. And so we have a bunch of these receptors in our brain, and guess what? They all contain CB1 receptors. So there's something about it that, when THC binds the CB1 receptor, it's sort of down-regulating the nausea effect. Again, these mechanisms are not well understood, but it certainly does help. I can tell you I have a lot of patients who, even before they start their chemotherapy, I certified someone today, brand new pancreatic cancer diagnosis, starting chemo tomorrow, and his wife was like, I'm going today, I'm going to buy it and get the vape for him so he has it. As soon as he gets home from chemo tomorrow, he can start using it. And I find that makes all the difference, because some of these chemo regimens are very highly nausea producing. So it's very helpful to have this on board very early on. For cancer-associated pain, I talked a little bit about that, but there's CB1 receptors all over the brain, and so it's not well understood exactly how THC and CBD modulate our pain, the way we perceive pain. But it's definitely something that we see anecdotally all the time. We just don't have a good understanding of the mechanism. Anorexic cachexia syndrome is just to say that we see a lot of wasting in patients who have cancer. They're not eating, they're shedding pounds, and this has to do with just the physiology of what cancer produces in our bodies, irrespective, even if they're eating. A lot of patients can't keep the weight on. So as I said before, this is one of the biggest indications that I'm certifying patients for medical cannabis for. Now, there is really not a lot of good literature out there for this indication. I refer to one trial that was conducted in the 70s. I say that it was probably just a bunch of hippies who got the munchies after smoking. Not really a robust study. So this is the hot topic. I get asked this pretty much on a daily basis, or basically told that they're going to be using the cannabis as an anti-cancer agent. No, so as a physician working in Western medicine, I can't say anything but, I say, well, there's no studies, do what you want, but I can't tell you one way or the other that this is actually going to help kill your tumor cells. What was interesting was that in 1975, There were some effects noted, anti-tumor effects noted on a lung cancer line in vitro, meaning, in the petri dish. But these studies were never really followed up, and I don't know, you can say what you want, but it has me thinking that, there was probably some underlying motives as to why this wasn't better studied. That being said, I have plenty of patients who are lifelong smokers, of cannabis, who come in and still have cancers here and there and everywhere. So, I don't know what's what. But if it were me, I don't think it would hurt to incorporate some cannabis oil into the regimen. Now there's something called Simpson oil. Many of you have probably heard about RSO, and I hear about it all the time. I have lots of patients pull it out of their pockets and show me it's a very high dose extract of cannabis. It's like a black tarry substance. It's really, really psychoactive. Not many people can handle it. Rick Simpson is a Canadian who says that he cured himself of stage 4 cancer, and so a lot of my stage 4 cancer patients are going to do anything and everything to try to treat their cancer, and so it's not unheard of for people to try to either obtain this or even make it on their own. So it's something just to be aware of. But again, the studies are lacking. I hear there's stuff going on in Israel. I'm anxiously awaiting some data. The Entourage Effect is something you'll hear about, talked about, and it basically, I was alluding to it before when I said how dronabinol really doesn't work as well as just a single isolate THC when compared to a whole plant extract, when you're talking about all the different elements, the CBD, the THC, the CBN, CBG, terpenes, fatty acids, all these things together, and what do they do in the body as they work together. That's considered, they call that the Entourage Effect, meaning that everything together works better than just in each isolate on its own. So there are a lot of factors that influence the effect that cannabis has on the human body. Of course, the dose consumed, are you using 2 milligrams of THC or are you using 15 milligrams of THC? There's going to be a big difference there. And so I always, bring it down to the milligram dose. When patients are calling me asking about, well, should I take more or less? I'm taking a milliliter. What's in a milliliter? I need a milligram dose, just like you would with your Lipitor or your Lopressor, the same concept. We're talking about milligram doses here. The different ratios of THC to CBD. Now, I'll get into the nitty-gritty of the New York State program in a minute, but we balance everything out in ratios. So is it a 1-to-1 balance ratio? Are you taking more CBD than THC? So that will affect how it affects the human body. How are you taking it? Are you inhaling it? Eating it, although that's not legal in New York State. Are you taking it sublingually under your tongue? Overall age, health status, whether or not they're naive or they're a lifelong user, all these things affect how cannabis is going to, affect the human body. Now there are drug interactions, and I think it's really important that people know that when they're taking, lots of people are taking lots of drugs, and so I always review my patients' drugs, but at the end of the day, I do rely on the pharmacists at these dispensaries to really do a lot of cross-checking, because I can't do it all, but it's really helpful to have the pharmacist there. And this is what I'm very wary about with other states that don't have cannabis dispensaries that are staffed by pharmacists. I'll give you a brief story. When I went to see Dr. Michel and speak, it was at a conference in Colorado. And so I was there with a bunch of East Coast clinicians, and we thought, well, let's check out a medical cannabis dispensary, because we're all from more restrictive states with very simple programs. And this is back 2 years ago now. And so we went to a medical cannabis dispensary, and we asked the guy at the front if we could speak to the person running it. And so sure, we waited for a patient to come out, and all of us walk in, and we meet this guy. He must have been about 23 years old. And I'm sorry, but he was like a stoner, and I was like, what kind of medical knowledge does this guy have? He's dispensing medical information to people. And it was very complex, all these different hybrids of plants, and nothing like we have here in New York. And we started asking about, THC and CBD and what has more, and he really didn't know what we were talking about, and he asked us to leave. And so we realized that it's really the wild, wild west out there when it comes to, how people are using this stuff. They just know things like these funky names, Girl Scout cookie and purple cushion. we don't speak that language here, so it's very difficult for us to be on the same page, and I think that's a lot of the problem that we're encountering in the medical cannabis world, just here in the US, forget about other countries. It's such a patchwork of different programs, and we need some uniformity, because there's a lot of misinformation out there. So like, what would a guy like that know if the patient was on warfarin and he's giving them, you know, X number of milligrams of CBD or THC to take? He doesn't know. That's the problem. So there are some contraindications. Absolute contraindication, at least in my book, is acute psychosis or unstable psychiatric conditions. I had a really unfortunate case last week where I had a patient with a diagnosis of schizophrenia and newly diagnosed widely metastatic lung cancer, having lots of pain, appetite issues, and it broke my heart where I told her I could not certify her. I could not do that. I wouldn't be responsible for her going into some sort of psychotic episode. And I don't normally have to do that because I don't see a lot of schizophrenic patients, but if they come my way for cannabis, it's going to have to be a hard no. Relative contraindications include, you know, severe cardiovascular disease, liver, kidney, immune disorders. Now, these are all relative. For the most part, at the doses that patients are taking cannabis, not really significant harm. I always just follow the mantra of keeping THC low. Side effects I talked about for the most part. I just include this because there is a DSM-5 diagnosis, meaning in the psychiatric manual of psychiatric diagnoses, that there is a cannabis use disorder diagnosis that is recognized, and it's not to be, you know, shoved aside either. It's something that we should recognize. I rarely see it, however, compared to you know, the other addictions that we see out there. And there is a withdrawal syndrome, but I have yet to see it in my medical users. This is more for recreational users for the most part. Okay, let's get into the New York State Medical Marijuana Program. So in June 2014, Governor Cuomo passed the Compassionate Care Act bill, and the program launched officially on January 7, 2016, which I find really like kismet, because that was actually the first day I started working at the Cancer Center at Northwell, and so I felt like it just sort of all lined up for me. So I thought, let me just get certified with the program and I'll see what this is all about. I didn't realize it would blow up, you know, into what it has been. At the time, there were 5 registered organizations, each of which was allowed to have 4 dispensaries, so that left 20 dispensaries for the entire state of New York. We had one in Riverhead, Columbia. We had one in New Hyde Park, Minutemen. Oh, they were Bloomfield at the time. And then we had one in Queens, Stereo Health, and I think 1 or 2 in Manhattan. And that was it. And upstate, even worse. Some people had to drive 3 hours to the nearest dispensary. So in August of 2017, they added 5 new organizations. Now that just meant that they were then allowed to start growing and, you know, extracting their medicine, the cannabinoids. They are slowly popping up now. So there's every few months I'm seeing new ones pop up in the area, which is promising because it gives more variety, more, you know, more convenience for the patients. So in order for a practitioner to be qualified, it doesn't take too much. I just can't get people to get onto the program. You have to be a physician, an NP or PA in practicing medicine in the state, obviously, and complete, I think they even made it a 2-hour course now. It was a 4-hour course when I took it. I think they made it a 2-hour course and then register. And then literally after you take it, you just email the state, you know, that you did it, and you send them your DEA number and some simple stuff, and then you have access to start certifying patients. No one wants to do it, however, so that's the problem. So when the program first started, these were the serious medical conditions that one had to have in order to be qualified for the program. So you have to have 1 serious medical condition and 1 qualifying symptom. So this was the original list. And then came chronic pain in March of 2017, followed by PTSD, and then pain that degrades health function as an alternative to opioid use. They realized we need to get more patients on this program. It does help with lowering opioid use, and we're in an opioid crisis. So they added that as a qualifying medical condition, which is very general. But when they opened the doors to chronic pain, I think they more than doubled the registrations that were happening. Certainly, I was seeing the one patient that day, and I was about to tell her, I can't put you on the program. And then it was the day that chronic pain was put onto the program. I said, oh, actually, I can put you on a program. And then it was like, it wouldn't stop after that. I just got so many chronic pain patients coming my way. I no longer take chronic pain because I just couldn't keep up. Substance use disorder was added later on. And then the clinically associated conditions include all of these. And the PTSD was added later, and opioid use disorder was added later. But really, it was about either you have to have seizures, you can't just have cancer alone. You have to have a qualifying condition. So cancer and you're having severe nausea, cancer and you're having severe pain, or wasting, appetite loss, that sort of thing. So you have to have one from each column. These are the approved modes of administration in New York State. So we have the vapes, so those are inhaled, capsules, tablets, liquids or oils or tinctures. Tinctures are alcohol-based, for those who don't know. They absorb well under the tongue. Oils, for the most part, they say to swallow and take with something fatty. That's what I've learned from the pharmacists. Oral sprays, oral powders, and suppositories. Now, oral powders, it's interesting because one of the dispensaries actually tells patients, well, just put it in your baked goods. That becomes an edible, and I thought edibles were illegal in New York State. But so smoking and edibles are supposed to be illegal in New York State. They initially had this really asinine limitation of 10 milligrams of THC per dose, and I thought, that's ridiculous. You can't put a cap on that. Some people will have no effect at 10 milligrams. It's so silly. They got rid of that. So the sublingual oil tinctures, they usually take about, they say 30 minutes per onset, but I think it's quicker than that. I think it's about 15. People will start to feel effects. It lasts anywhere from 4 to 6 hours, the effect. Vaporized what I like about the vaporized form is you know right away if it's working. If you inhale, it's immediate to a few minutes, and it lasts, I would say, even shorter than 2 to 4 hours, probably like 2 hours max. But the nice thing is you can dose yourself more frequently. I think my patients who are having more, severe pain that comes on suddenly, would be best served with the vaporized form. Not that I'm, a big proponent of vaping. I don't think we know the long-term effects of vaping. But a lot of my stage 4 cancer patients aren't going to, see the effects 20 years down the road. So it's more about the here and now. So that's what I'm concerned with. And my capsules are 1 to 2 hours to take effect, and then about 6 to 8 hours. Although I would venture to say maybe even closer to 10 hours. I usually do twice-a-day dosing with the capsules. So I took this from Vireo Health's website. I like how they have the spectrum on their site. And it really encompasses what we have here in New York State. I actually pull this up every time I certify a new patient so that they understand what the THC and the CBD spectrum is. Because me talking about it and even writing it out on paper doesn't really do it as much justice as giving them a graphic to focus on. So we look at the left where we have the THC dominance. So they color code them at this dispensary. They may give them funny names at other dispensaries, whatever. But their reds and their yellows are the THC dominance. I'll never start there for a THC naive patient. And then the CBD dominants are the indigo and blue on the other end. And then right down the middle you have the green, the balanced 1-to-1 ratio. Now for my cancer patients, I tend to start with the 1-to-1 ratio for the vast majority of them, even the THC naive, because the balance works nicely because really all of them need THC. I mean, they're coming to me because they have cancer-related pain or nausea or neuropathy or whatever it is. They need THC in there. It's just a matter of balancing out with the CBD. And the CBD does a nice job to balance out any of that psychoactive property that THC might have. So for example, if they were to start out with 5 milligrams of THC alone, they're not THC naive, they're probably going to feel a little fuzzy, maybe, get a little drowsy or dizzy or whatever the case may be. If they were to take that same 5 milligrams of THC and take it along with 5 milligrams of CBD, the chances of them becoming so disoriented are less, because CBD, I like to say, anchors some of that psychoactive property of THC. So the one-to-one really is my go-to starting point. In the beginning, I didn't know what the heck I was doing. I was putting everybody on indigo. And it just like, because we all thought that, the other practitioners who were doing this were doing the same thing. You have to work your way down from the right to the left. That was silly, and we didn't know any better, because the course doesn't teach you anything. So everything was just, everything I learned was self-taught. I did a lot of reading on my own time. I mean, sorry?
You're reading in Hebrew.
Oh, exactly. So now I know better. I start with the one-to-one, unless, and there's some places where I wouldn't do that, and if I have someone who's coming to me because they, I have a lot of patients trickle in who are not necessarily cancer is not their issue. It's more, chronic pain, osteoarthritis, fibromyalgia, anxiety, insomnia. I'm seeing that's intertwined with everything, not just cancer patients, everybody. And so if I'm certifying, a little lady who's 88, who is anxious and can't sleep and she's in a lot of pain, I might start with the CBD heavy because I don't want to give her a reason to feel intoxicated and cause a fall and a hip fracture, God forbid. I get really, really conservative when I deal with my elderly patients. Or patients who are prone to anxiety. If they have a lot of anxiety and a lot of chronic pain, might end up doing more of the CBD heavy rather than starting out with a higher concentration of THC. Those are just some of my rules of thumb. So what happens is the certification process goes as follows. The practitioner makes the recommendation. This is never called a prescription. Everyone talks about prescribing cannabis or prescribing marijuana. We can't say that. This is federally illegal. We are making a recommendation. So we go into the Health Commerce website, which every practitioner has access to in New York State. But then we get special access to the marijuana database once you do the registration. And I have it down to about a minute and a half. I can do these certifications very quickly. So it takes no time to do it, really, once you know what you're doing and you certify the patient. The max is 1 year. However, depending where you go, there's going to be different practices. And I've heard lots of shady things happening, like 1 year, 1 month, and come back and pay me another $300 and you'll get another month. I've heard it all. But I do 1 year and that's it. Then the patient has to do some homework. They have to take that certificate and the registration instructions and register on the NewYork.gov website. This is a Department of Health run program. I got to take out that $50 fee. That was from my original talk. That they used to do a $50 fee. Then they got rid of that. It's all free. So you get your card in the mail, and then you go to the dispensary with that card and with your certificate, and that's it. Now they've made changes to the program over the past few years to make it much better and easier. So now you can print a temporary pass, so you don't have to wait a week and a half for the card to come in your mailbox. You can go, I've had the quickest turnaround I had is I met a guy getting chemo, head and neck cancer, really lots and lots of pain, trouble swallowing, it was awful. And he had his laptop, he put his registration in, he left the cancer center and drove to the dispensary and got the product. I mean, that was the quickest I saw. And so now they've made it a lot easier, because in the past that was not possible. However, I just put this in, oh gosh, I thought I updated the numbers. I did it on another presentation, sorry. Then the latest numbers were something like, 1,500 practitioners, or maybe 2,000 practitioners, and like 50,000 patients. That's not a lot, And I include the population of New York there to show you, and if they say 10% of the population or more has chronic pain, we're not touching, most of the people who could benefit from cannabis. So there's lots of obstacles to getting this more mainstream. We don't have a lot of studies. That's the hard truth. And the fact is you can't really do good studies on a federally illegal substance. If you want to get grant funding and things like that, and really do robust studies. So it's kind of ridiculous what you see when you check the literature is you just see a lot of surveys, a lot of observational studies, and I've done surveys and observational studies. And I'm not poo-pooing on them, but it's a matter that that's not really what the medical community wants to see. They want to see randomized control trials, and how do we get that done? How do we get that funded? You need to at least reschedule cannabis to a Schedule 2 alongside cocaine, because cocaine is Schedule 2 for those who don't know. So it's just a matter of getting it more accessible so that we can do studies more easily on it. And let's see. So there's a good future for cannabis research. However, I think a lot of what's happening right now, and this is just my perspective. I went to this conference a few years ago, and my eyes were really open to what's going on in the cannabis world. But a lot of this is pharmaceutical company driven. So they're looking to find different ways to bind those receptors I was talking about and modulate these pathways rather than looking at the whole plant. And because no one makes money off of you growing your medicine in your backyard. I'm going to tell you about Mrs. B. So Mrs. B is a patient I met in March of 2016, and I still take care of her. She came to me, she was scheduled to see me, and I was waiting in the office to see her. She was a patient of my geriatric colleague who had sent her to me for her chronic pain. And she didn't show up, and so as I'm waiting in the office for her, I have the secretary comes over and says her daughter's on the phone. They're in the ER, and I said, oh. So I pick up the phone, and she says to me, my mother had been using tramadol for her pain, and really, she just couldn't take it anymore. She had this lumbar spinal stenosis with this horrific, shooting pain down her legs. And for anybody who suffers with any spinal issues, you can empathize. She ended up taking a handful of the tramadol in an attempt to commit suicide, and her daughter found her unresponsive that morning, so brought her to the ER. So I ended up going over there eventually anyway, and I met her, and I said, hi, come back in 2 weeks, make another appointment. And so finally I met her, and we did the certification, got her on the vape. She wanted to do the vape because it was fast acting. And I did a follow-up, I guess maybe 3 or 4 weeks after she started taking the cannabis. And she was a different person. Her daughter said, I haven't seen her like this in years. She sings, and she's doing little dances around the house, and it was amazing. Just what a transformation happened, in her. And I took this picture because it was one of my first patients, using the vape and with her walker in the background. And it just goes to show you that, you're never too old to benefit from this, as long as you're using it responsibly. So in summary, cannabis is generally well tolerated. Serious adverse effects are rare. There's no lethal overdoses, as I've said. It should be avoided in those at risk of psychosis. There are good data to support its benefit in nerve pain, MS, epilepsy, but we're lacking in large randomized control trials, and so that's really where the need is. Thank you.
So we're going to do some questions, and I'm going to bring the microphone, but I want to remind you, do not ask specific medical questions about your own medical history, because obviously we can't do that in this type of setting.
Hi, I'm a Medicare counselor for the Department for the Aging. Is this covered by Medicare?
Absolutely not. No, so this is not, thank you for bringing that up. I meant to talk about the coverage. So when you're talking about a federally illegal substance, it's not covered by any health insurance, nor is any credit card company covering this transaction. It is a cash only. They do take debits. ATMs are outside all the dispensaries. So, it looks like a really, sort of shady process that's going on. But it's all legitimate because this is what the dispensaries have to function under.
So how much does it cost for someone to get this?
So it's highly variable, so my 88-year-old little old lady might have a very low tolerance and get by with just a smidgen of the oil, and taking that once or twice a day does her well, and so she can spend $150 a month, you know. And I have others who are vaping, who are taking capsules and oils, and they're using all different forms multiple times a day and spending $500 plus a month. Definitely.
Any other questions?
Hi, can you talk a little bit about the CBD oil that is dispensed medically and the CBD oil that you see advertised all over the place, drugstores and Happy Farms, meat market, and really everywhere? Can you just talk a little bit about that?
Yeah, so it's become the real bane of my existence on a day-to-day basis. And it's not to say that hemp CBD is not helpful, because it can be for many people. So what you're seeing sold everywhere these days is from hemp. And hemp is a cannabis plant. However, what distinguishes the hemp plant is the lack of THC in it. So that's what makes it different than marijuana. So hemp flies under the legal radar, as I say, because it is legal to sell, and you can buy it off of Amazon or anywhere, and it can be shipped across states, unlike cannabis. So people are using it all over the place, and so it can be helpful, and I dose it in patients all the time. It's just a matter of the variability. I can't tell you how many different types I've seen people pull out and it'll just say some random, company hemp extract, and it gives me a random milligram dose. I don't know what hemp extract means. What's in the extract? And so at Northwell, we recently hired a natural therapeutics pharmacist who happens to work at a dispensary on the weekends. So she understands cannabis pharmacology. So, obviously we've become like this, and so she said, well, we want to start selling some CBD products out of our pharmacies, stuff that we vetted, that we know is high quality. So she spent a good month researching various companies, and we came up with 3 different companies that she found in her own research, and even trying it out on herself to find that it had the best quality. She spoke with their representatives, she looked at lab reports and looked at all the data, and there are good companies out there, but I think they get drowned out by a lot of the junk. I was at a street fair in the fall last year, and I saw 2 different tents set up with this CBD and hemp, and they put the marijuana plant to make it all, trendy, and I don't know, I'm very, very wary about all that. And the problem for practitioners is that we're just now seeing it all over. People are dosing themselves. There are effects from CBD. There are drug-drug interactions, like I showed you. I now granted, some people will get good response with very high doses and keep themselves off of more harmful agents. But at the same time, you have to be under the guidance of somebody who knows what they're doing when it comes to cannabis medicine.
Thank you. This has been incredibly informative. So now, as a layperson, you and your colleague have identified 3 dispensaries.
3 hemp CBD companies.
3 hemp CBD companies. How would I, going home now, be able to identify those and not be caught up dealing with the hippie that was doing drugs in the corner when I was in college 100 years ago?
I can just tell you the names of the companies. Charlotte's Web, Elixinol, and Cambiola. There are other good companies out there, but these are the ones that we decided to start selling at our Northwell pharmacies.
Can you repeat it again?
Charlotte's Web. Charlotte is a girl who suffered with intractable seizures, and her parents, I think, moved her to Colorado, if I'm not mistaken, to get her the CBD she needed. This is many years ago now. And they ended up making their own company, using her name. And they're a really reputable CBD brand. Cambiola and Elixinol. Those are the 3 brands that we sell.
How do you spell it?
Elixinol.
Are you finding as a practitioner a lot of patients being frustrated because of the financial cost and it's just exorbitant for so many people that we see? So where do you see this going, moving forward? I think you're doing, and I appreciate you're offering to the patients other options, but just where do you see it moving forward with the costs?
So this is why I was so happy to see more dispensaries opening up. So I don't do any of this for cost. I have the luxury of being an employee for a large health system. I charge nothing for patients. I've certified close to 900 people at this point, and I've made nothing more than just charging for a palliative care visit, to their insurance company. So cost is never an issue. It's not something I look at. So I was really happy to see that there were more dispensaries opening up, because this is just simple supply and demand. If you have more competition, it has to drive the cost of some of these products down for them to maintain their patient base. Otherwise, they'll lose them to the other dispensary opening up a few towns over. Now, there's a lot of talk about legalizing recreational cannabis in New York. I think yesterday something came out where it might be more of a standstill. I don't know where we're going with this. Once that becomes legal, because I think it's inevitable, how will it? I don't know for sure how it'll affect the medical program. They don't seem to. The dispensaries I've spoken to don't seem to be very concerned about losing patients, because they feel like the tax rate will be lower with the medical, so they'll retain those patients, whereas the tax rate's higher for the recreational use. So they seem to be confident that they'll retain their patients. But what has to happen is we need to get this. We need to have more of a supply coming in, and until it's more readily flowing, at least in New York State, because you go to Massachusetts or Colorado or Vermont, the same product is half the price in many instances. That's frustrating for me, for my patients. If I want them to be taking something regularly, and we're sort of, their symptoms are relying on this particular dose of the cannabis, but they can't take it on a regular basis because of cost, that becomes a real issue. I think things will get better and more and easier for patients to access over time. I just don't know what that timeline looks like.
Thank you.
Someone in the back had a question.
Have you heard of the company Salty?
No.
Okay, cause I'm wondering, it's like a herbal tea company, and they just recently infused their product with CBD.
Well, everyone's infusing CBD into everything. People are putting it into the air in some of these spas. I mean, I don't know what the heck that means, though. And that's what frustrates me. Infusing. I think I saw it in Fairway or Harmon Face Values. They're selling, Whole Foods. Yes. So they're all selling these CBD products. So I saw CBD Diffuse. I don't know what the data is to diffusing CBD into the air and what that does for you. I mean, is anything actually absorbing into your bloodstream? I think it's all just propaganda.
I have a two-part question. In states where it's legal, do the insurance companies cover it there?
No.
No.
It's because it's federal. So this is a federal issue. There's no getting around that. It doesn't matter what state you're in.
And how would you suggest that people, try to think the word to use,
Advocate?
no, advocate to change the law?
Well, my answer to that is usually politically incorrect. Because you have to vote in an administration that's actually going to do something on the federal level to change the laws. And there are some people running for president right now who have very progressive viewpoints on medical cannabis. I can't speak to the other viewpoints, but I know that on medical cannabis there are some candidates who are looking for federal legalization, not recreational, medical. There's a big distinction here. I think a lot of agencies out there push for both, like Doctors for Cannabis Regulation. I don't join them because they're really pushing for recreational legalization. I don't give a hoot about that. I really care about legalizing medical for everybody. Then let's talk about recreational another time. Medical is where it's at right now, I think.
Thank you. Just following up on the point about access and care, the three other options, the other companies that you mentioned that have hemp CBD that are sold at Northwell and potentially other places, are those more affordable for patients?
No. Not at all. I mean, I think with anything else, a lot of it has to do with the better the quality, the higher the cost. Yeah, and so it's worth saying that just because I have a patient taking hemp CBD for their ailments, it might not be more cost effective than going to a dispensary. It's, a lot easier because you can just order, repeating shipments from the company online, rather than going through the whole rigmarole of going through the dispensary process, which, I make it easy for my patients, but a lot of the practitioners out there do not. Like I said before, there are some practitioners, you gotta pay a $500 initiation fee and then come back every X number of months. There's memberships, yearly memberships of $1,500 or so. I've seen this, it's really, and then that's not even including the cost of the medicine. So people are really squeezing people dry, really making it a cash cow. So CBD, if you're getting good quality CBD, I can't say it's much more cost effective, unfortunately.
Does the quality vary from dispensary to dispensary? Is it
Oh,
different?
great question. It's hard. So it's hard for me as a not someone who's not, testing them out between them. But I ask my patients. Some of them, and I get very mixed reviews. And I think it's because everyone is so different. And I tell each of my patients that you will respond to THC differently than the next person. Even your brother or sister. It doesn't really matter. It's a very personal thing. So I have some patients who will go to one dispensary and find that their products don't have any effect on them, but they go to the next one and they love those products. And I might hear the exact opposite from someone else. So, what I don't know what has something to do with the extraction method or what they're reconstituting the medication in, because oils and tinctures are different products and capsules and tablets are different. Maybe it's just the way they're taking it. Then they have different ratios. One might have a 1-to-20 ratio, one might have a 1-to-15 ratio. So there's so many variables. It actually is very frustrating, and I think for a lot of practitioners, it's a bit overwhelming. That's why they don't want to get involved. They feel like, first of all, they think their license is going to get stripped from them. They think the DEA is going to come knocking on their door, which is not true. There's a special exception for these cases. So the DEA has bigger fish to fry than dealing with this sort of medical transaction. And so they just don't want to get involved with it. I forgot what else I was saying. Sorry.
There's no quality control.
I mean, so I'll say this: every dispensary, so they each have their growing facilities, right? And they're all located somewhere upstate. They have to send their samples through a central laboratory, so everything gets quality, purity checked, and everything. And so for a lot of patients, while they may find that they can get the same effects from getting from their friend on the street, getting it, just smoking it. I have patients who will spend, double the cost, but they know that they're getting quality product that's been checked and it's pure, and they don't have to worry about things being laced, and that's enough for them to want to spend the extra money to make sure that it's, it's pure. But however, I just can't say, some people will just respond better to one dispensary's product versus another. So I always tell them it's worth, shopping around if they can do that. Because if one dispensary's products don't work well for you, it's not to say that the next dispensary wouldn't work better for you. We need more standardization.
I noticed that warfarin was affected by, was it the THC or the CBD?
Both.
Both, okay. So how does that affect, I have different clients that have a lot of pain or whatever, they're on warfarin, and they smoke marijuana.
Yeah.
So will that affect it the same way as taking that?
Yeah, most likely. Now, it's sort of like the whole, if you know anybody on Coumadin or warfarin, they tell you, they always say to you, oh, well, I can't eat leafy greens. And that's not true. You have to just take the same amount of leafy green every single day. It's about consistency, because it'll affect the dose that you're taking. So if you start taking leafy greens, if you start taking cannabis, then you have to sort of be regimented with it to keep the dose of the Coumadin the same, because then the dose might be going haywire in your body because you're affecting its metabolism. So, if they're getting their levels checked regularly, it's something to take note of, but they have to be consistent with it.
And my last question is this available PowerPoint? Can we download it? Where would we get this from?
So we'll put everything up on our website next to the video, on the Adelphi Breast Cancer website.
Going back to the one, is there a difference between a cream versus
Oh,
something
topical.
internally?
Yes, thank you for bringing that up.
With water.
Oh, with warfarin?
Yeah.
Oh no, I think it's minimally absorbed into the bloodstream. I didn't talk about topicals though. They are, they're not readily available in New York State, but we're getting there. But one of the dispensaries taught me a trick. They said that until they had their topicals ready for sale, they were just telling people to take their tincture and mix it in with whatever cream they would like to use. Let it sit. They probably have a recipe. Let it sit for a period of time, and so it all absorbs into the cream, and then apply it topically. And I find that topical cannabis or topical CBD, for that matter, can be very helpful for localized pain. Like a back pain, a knee pain, things like that.
Any other questions?
I'm told that some of the dispensaries have a mail order program so that for people who have difficulty getting to the dispensaries, that's an option. And I think the New York State program also allows a caregiver to be designated so that if a person is not well enough to go on their own, they can have the assistance of the caregiver handle it for them. And there's a process that they have to go through to have a designation made.
Thank you. Yes. So every patient is allowed to designate up to 2 people to be caregivers for them. That person registers themselves when you do the registration process for the patient, and they will get a card as well. And that allows that person to go to the dispensary either with the patient or for the patient. Because I don't know how it is lately, but in the beginning, you weren't allowed entry behind the double doors if you didn't have a card. So it's, or even pick up the delivery at the door for the patient. So say you have a really sick patient who can't get out of bed. Well, they can't leave it with that patient's wife who's answering the door unless she has a card too. So that card allows basically you to be the proxy for the patient for all things to do with the program. And yes, there are some dispensaries that offer delivery. Vireo Health is the only one I know of that does free delivery. Columbia Care charges $30, and I think Curaleaf is going to be rolling out delivery services shortly.
Any other questions?
Oh, yes, I have one other question.
Hold on, we have one back.
One in the back first.
Hi everyone, my name's Allison. I'm actually an employee at one of the local dispensaries. I just wanted to introduce myself very briefly if anybody had questions. I just also wanted to note that Curaleaf did start our delivery program about 2 weeks ago. It's free for all of our patients. They can call in, do their consultation with the pharmacist over the phone, go over all the products and schedule the delivery. I don't want to take up too much time, but yeah, it's been a really great program so far, and it is a free program with just a minimum delivery.
Great info. I will keep you guys busy with them.
If a doctor doesn't know anything about it, where do they go to get information? I have a client who has all kinds of pain, and her doctor said that he couldn't prescribe it because he didn't know anything about it.
So I mean, that's a twofold answer. So many doctors, and I think I can speak for them, is that they're really busy, and that reading about another topic is onerous and time consuming, and people don't want to do it. And I understand that fully. But then you have people who do want that information. The Cannabis Pharmacy is a good book to start with. It's on Amazon. You can find it anywhere. I find Americans for Safe Access, that website, to be very helpful. It can be overwhelming because there is a lot of information both for healthcare professionals and for patients. It links, it has such a repository of data there, every study for every, even down to the basic surveys I was talking about, anything and everything that was published on cannabis, you can access through that website. So it's very helpful. It might be a little too much for someone just starting out, but the Cannabis Pharmacy is a good book.
I work in a hospital, and I just wanted people to know that if you are on medical cannabis, you can bring it into the hospital with you. You don't have to not take it in the hospital. It just has to be certified by the pharmacy in the hospital, and it's an onerous procedure, but
So
we'll do it.
It depends on the hospital. So I help to write the policies and procedures for Northwell's hospitals. and we allow the oil, the liquids, and the capsules, tablets. Vapes are not permitted in hospitals. Period. Any facility. Just that's a Department of Health issue. There's no getting around that. Trust me, I was basically screaming in a nurse's station about my nausea vomiting patient who was in the hospital for nausea vomiting, doing worse because she couldn't vape. And that's when I got that. I got that email from the nursing supervisor. So I learned that the hard way. However, most hospitals, I think, to this point, have gotten some sort of policies and procedures underway. When the program was first rolled out, however, there weren't a lot of hospitals. Because I attended the Greater New York Hospital Administration meeting, and these hospital systems were very scared to get started. But now I'm very happy to know that lots of hospitals are allowing their patients to continue it. It's a patient may take home ed. They keep it on their person. And
they take it themselves.
Yes, they don't. The nurse doesn't administer it.
How do you go about getting your medical card? I was wondering.
So you have to go to a registered practitioner and get certified for the program if you meet the qualifying conditions.
Okay.
Mm-hmm. There is a public list of healthcare providers who are registered with the program. It's not all encompassing. You have the provider has to check off that they want their name publicized, and then a lot of it is anybody who was registered with the program. I know a lot of them who have never done a certification. So take that list with a grain of salt.
What's the name of that website?
You just Google. It's through the New York Department of Health. If you just Google New York medical marijuana providers, it would be one of the first things that pops up.
Any last questions?
Curaleaf.
You can ask her later.
What was the question?
Where does she work? Which dispensary does she work at? It's in
Why
Connecticut.
don't those of you who have questions for her specifically, you can go up to her afterwards. Any other questions? Well, let's give Dr. Martins-Welch a big round of applause. And please fill out the evaluation forms that you have. This form came directly from someone who recommended we do a form on this. So we take your recommendations very seriously. So if you have ideas, please put them on the evaluation form. And then you can either hand them to me or anyone else on staff at the front desk. Thank you.